So if we now go to pressure control, what I'm going to do now is ask the ventilator to do something essentially completely opposite of what I was asking it to do before. In volume control, I was asking the ventilator to deliver a certain amount of volume over a certain period of time. And as such, the ventilator had to deliver the flow at 30 liters per minute in order to get this volume in 1 second. So if I now go to pressure, what I'm going to ask the ventilator to do now is deliver a certain amount of pressure over a certain period of time, not a certain amount of volume. So if I set my pressure at 20, what I'm doing is asking the ventilator now to deliver a certain amount of pressure over a certain period of time. Notice up here there is no flow rate. So why is there no flow? Do we not deliver flow when we're in a pressure mode? So yeah, we deliver flow, but what has to happen, flow has to be variable when we're in a pressure mode. And the reason it has to be variable is that depending on the size of the lung, it will take more or less flow to get to the pressure point that we tell the ventilator to go to. So flow for a baby, might be, with a lung this big, might be very, very low, but for a patient that has a lung as big as this room, flow would have to be huge in order to get to that pressure point in a very short period of time. So if I accept this now, we see now that the waveforms change, and now what I'm doing is delivering a constant pressure, and that's what I'm asking the ventilator to do. And in order for the ventilator to do this, it has to deliver a certain amount of flow to get to this pressure point. And once this pressure point is achieved, then flow decelerates for the I time, and then we go to exhalation. And so now we see that the patient's expiratory waveform, this triangle, looks a lot like the inspiratory waveform. So in reality, this is more like the way we breathe physiologically, with a rapid peak flow, and then we diminish our flow as we pull in because we can't maintain a constant flow. And as we exhale, our exhalation occurs basically the same way, where we exhale to some peak expiratory flow. And then as the passive exhalation occurs, the flow rate slows back to baseline for a moment, and then we deliver or take the next breath. So once again, in terms of talking about the area under a curve, this area underneath this pressure or this flow curve is the amount of volume, is that volume of 454 cc's, if we were to know what the I time is and what the deceleration of flow is over that period of time, we could calculate the amount of volume in that curve. So if I change the amount of pressure that I want, the ventilator now needs to deliver less flow to get to that same pressure point. So less flow over the same period of time is less volume. So with pressure ventilation, we need to monitor the amount of volume we're delivering dependent upon what the compliance is of the lung that we're dealing with. So if I increase my pressure back to 20, in this case, with this particular lung and its compliance, we are delivering approximately 450 cc's here, and at the compliance that we're currently at. But if I squeeze this lung, I haven't changed this number at all. The ventilator says, well, now I have to deliver flow to a smaller lung, essentially, or a less compliant lung. So I deliver less flow is less volume. So if I wanted to maintain a tidal volume of 500 cc's, what would I have to do? I would have to increase the pressure, titrate the pressure up, watching my volume as I increase that pressure, assuming my compliance is going to stay the same, until I saw the volume coming back again that I wanted, right? So then if the patient diuresed, it was congestive heart failure that caused this compliance problem, and now we come back a little while later and we see a tidal volume higher than what we want. When we're in pressure control, we have to turn the pressure back down again to get back to the volume that we want. Okay. and we want about, let's say, a 500 cc tidal breath, or thereabouts. So in pressure, we have to be aware of what the pressure is in order to deliver a certain volume, so we're not damaging the lung with volume trauma, and we have control over the barotrauma because we have control over the amount of pressure that we're delivering. And the ARDSNet and other studies have shown that we want to limit the amount of pressure we're generating in the lung to somewhere between 30 and 35 centimeters of water pressure. We don't want to go any higher than that. So there's a big emphasis on maintaining peak airway pressures lower than 35, but some people also talk about maintaining a low mean airway pressure as well, so we don't want the mean airway pressure to go higher.
Or it seems that they really are more talking about the plateau.
Yeah, or plateau pressure. But interestingly, when you're in pressure, people get this confused. If we have an appropriate I time set, this is your plateau pressure.
Should be.
Should be, right. If we have the right I time set, right? Now, in volume control, we can't set, wrong button. We have the ability to set a flow rate, but we don't know what that flow rate is. We don't know what the demand is necessarily. We have different rules of thumb that we can use that would help us set an appropriate flow rate, but we have to just set a flow rate that gives us a reasonable inspiratory time. But in pressure control, we have the ability to set, by watching the flow waveform, an appropriate inspiratory time, and consequently, that in setting that, it would keep our plateau pressure as low as possible. So let me demonstrate. In the event that we had our inspiratory time set at, let's say, 0.75 seconds, notice that the flow waveform that we talked about, the area underneath this curve, is my tidal volume being delivered, and it's currently 374.76 cc's. And notice this point right there. That's the point at which the 0.75 I time is finished and the ventilator goes to exhalation right at this point. Well, based on what I said earlier about the area of this curve representing the tidal volume of the patient, if we were to allow the area of this curve to go down to baseline, so from this point down to this point, that little triangle that would be created right in there where the red dot is more tidal volume. So if we titrated our I time out a little bit further, and we don't know exactly where, but we'll bring it out here. Now my I time goes and flow goes down to baseline, and notice that my tidal volume is increased by, I think it was what, 350? Now it's increased by about 50 cc's. So what I've done in this case is that I've maximized the amount of volume that I can deliver at the lowest possible pressure that I can deliver it at. And that's the beauty of using pressure control or the mode PRVC to deliver volume ventilation, because you can adjust that I time to deliver the greatest volume at the lowest possible pressure. Because let's say your order was to deliver a 400 cc tidal breath, okay, and you were going to use pressure control or PRVC to do that. Well, and you came along and you set a I time of 0.70 seconds, you know, for whatever reason. Now you could say, well, the doctor wants 400 cc's, so I'm not at 400 cc's now, so in order to get 400, I have to increase my pressure. So I've increased my pressure now, and now I'm delivering the 400, so I'm happy. Everybody's happy, and so my supervisor comes along and says, what are you doing? And I said, well, he wanted a pressure control, and I'm using that, and he wanted a 400 cc tidal volume, and I'm delivering approximately that volume. And the supervisor says, well, you could do a lot better job than you're doing right now. And I'd go, what do you mean? I'm delivering, I'm doing exactly what he wants. I've got the, you know, I'm not too high, it's, you know, his pressure's not 35 or 40, and I'm delivering the 400 cc's. Said, well, his I time isn't set appropriate. So if you extend the I time out and create that little triangle there, what you've actually done is tailored your breath so that you can, now I'm delivering more volume than I want, so that being the case, I would titrate my pressure down so that I'm delivering the 400 cc's at the lowest possible pressure that I could set to deliver that 400 cc tidal volume. So you can adjust your eye time when you're in a pressure mode to help you deliver the greatest volume that you can at the lowest possible pressure, consequently minimizing any lung damage that you might create. Now, in some cases, you may not be able to do that, and you have to kind of choose a happy medium, because if the patient is breathing, if he's breathing very fast, notice that I'm cutting my, trying to exhale, but the ventilator won't let me exhale for that eye time that I have set. So according to this waveform now, you would want to shorten your eye time. So if I shorten my eye time, now that looks a little bit better, but when I shorten my eye time, I'm delivering less volume than I was before, so I might have to increase my pressure. So likewise, now that I've calmed down a little bit, now the waveform looks like this, and I go, well, geez, I could lengthen my eye time a little bit out, deliver a little bit more volume, so let me do that. But the problem is you're always chasing your patient, chasing him back and forth. So what you have to do is kind of find a happy medium between your variability in your patient's rate and your eye time that you set, so you deliver an appropriate eye time. Sometimes you'll see the breath like this because he's trying to exhale too soon, and other times you'll see it getting cut off too soon because he wants to take a deeper breath. So you might have to adjust, but you might have to be happy with a certain medium in between two different eye times.